I'm really happy to be here to present the 2-year progress of my PhD thesis, which is about tissue acquisition in solid pancreatic masses. My name is Engh, and as you all know, pancreatic cancer has a very high mortality rate, and it's usually due to the late diagnosis. So my vision is to improve the diagnostics of pancreatic cancer to lead to better outcomes for the patients. Now, I know this is a huge job, and I can only do a very small part by chipping away a little bit with contributing to clearer guidelines for the more efficient sampling of pancreatic cancer. For this goal, I have 2 topics. I have 2 meta-analyses about the diagnostic adequacy performing the endoscopic ultrasound-guided tissue acquisition by different techniques and materials. The first of these is a comparison of diagnostic adequacy of needle tips in endoscopic ultrasound-guided tissue acquisition of solid pancreatic masses. Endoscopic ultrasound-guided tissue acquisition is the recommended sampling method for solid masses of the gastrointestinal tract, including solid masses of the pancreas. 10% of these samples end up being inadequate for analysis, which carries a risk of resampling, with risk of adverse effects, the need for sedation, and costs of around $2,000 per patient. There are 5 current needle tip designs in use for this procedure. There's the F&A needles, which are the Engh type. There's the F&B needles, which are the reverse bevel Westcotts, forward bevel Westcotts, Francine, and fork tips. All of these are available in different sizes. Currently, the guidelines only recommend using the 19-gauge F&A or F&B needles or 22-gauge F&B needles to achieve a core tissue specimen. The level of evidence is low and the recommendation is weak. So our aim was to compare the diagnostic yield and adequacy of all the needles used in endoscopic ultrasound-guided tissue acquisition. For this, we set up a PICO with patients undergoing endoscopic ultrasound-guided tissue acquisition for a solid pancreatic mass with an intervention and comparator of any F&A or F&B needle and the outcomes of diagnostic adequacy, specimen yield, number of passes, adverse events, and technical failures. This is our flowchart of selection. We started off with around 3,500 records and ended up with 61 eligible full text, although these cover only 35 independent studies. We also updated the search in December 2022 as more studies were coming out. For our first outcome, which is the histological adequacy, you can see our network here. Each node represents 1 needle of 1 size, and the size of the node represents how many patients received this needle. The lines are direct comparisons, and the thickness of the line represents as well how many patients were in each direct comparison, and the number in brackets is the number of studies for this comparison. We set up a ranking. This is a p-score. It represents the probability that each individual needle will be the best for this outcome. As you can see, the fork tip and Francine needles performed the best, and the Engh needle the worst, which is not surprising considering that the Engh needle is not actually a histology needle. We also hypothesized that the size mattered less than the design, and therefore we set up this ranking disregarding the size, where we found similarly that the fork tip and Francine needle were the best and the Engh needle the worst. For the outcome of cytological adequacy, we were able to set up a network which included only the 22-gauge needles of all designs. However, for the ranking, we found again fork tip needles performed the best and the Engh needle the worst. Disregarding the size, again, the same is seen. The newer needles, the fork tip Francine needles, are performing the best, and the reverse bevel and Engh the worst. For the outcome of technical failures, we had the issue that a lot of studies had 0 event rates because these are very rare events. However, we were, again, able to set up a network. And in the ranking, we see that the Francine needles performed the best, and the reverse bevel is surprisingly quite low, lower than 2 of the Engh needles. Disregarding the size, here we also see the Francine needles are performing the best, Engh are surprisingly enough the second best, and the reverse bevel are the least likely to be the best. For the outcome of adverse effects, again, we had very low event rates, and we have very wide credibility intervals here, non-significant results, but we also were able to set up a network, finding that the reverse bevel needles are performing the best, and Francine and Engh the worst. So they're the most likely to lead to adverse effects. Disregarding the size, here you can see the color represents actually the difference between the needles. So when the color scale is not showing that strong of a difference, it means that the p-scores are relatively similar. So as you can see, the only needle that really set itself apart was the Francine needle with the lowest score. All the other needles are approximately equally probable at being the best for the outcome of adverse effects, which again are very rare events. In summary, there's a network meta-analysis including more than 50 studies and thousands of patients. We're comparing all the available needles for endoscopic ultrasound-guided tissue acquisition of solid pancreatic lesions in several sizes. However, we have high uncertainty leading to wide credible intervals. We have no statistically significant differences due to the uncertainty. But we would like to conclude that fork tip and Francine needles are the best for achieving adequate samples, and Westcott needles carry the least risk of adverse events, but these are rare events either way. In summary, we suggest that you choose fork tip of Francine needles if adverse effects and technical failures are not of concern. 22 gauge or 25 gauge fork tip needles are the best for tissue core, and further RCTs comparing several needles should be performed. Adverse effects should always be clearly defined in future papers, and the adequacy for cytology and tissue core for histology should be reported. This manuscript is currently in the article writing without final results because we want to add diagnostic parameters as well, so we're currently going through the papers again, extracting more data. However, our target journal is gastroenterology. My second paper is about contrast-enhanced endoscopic ultrasound. Now, the background is similar. However, during the endoscopic ultrasound-guided tissue acquisition, there are different types of ultrasound which can be used. One of them is the contrast-enhanced endoscopic ultrasound. Now, this leads to increased visibility, especially of fibrotic and necrotic areas. However, it also decreases the time window during which the sampling can be performed. So our aim was to investigate whether contrast-enhanced ultrasound may increase the sampling adequacy of pancreatic solid masses. Here, we were looking for randomized controlled trials on patients undergoing endoscopic ultrasound tissue acquisition for a solid pancreatic mass with contrast-enhanced endoscopic ultrasound compared to conventional endoscopic ultrasound. And our outcomes were diagnostic adequacy, specimen yield, number of passes, and adverse events. Our hypothesis was that contrast-enhanced endoscopic ultrasound would yield superior adequacy to conventional endoscopic ultrasound. We found about 400 records and ended up with 4 included full text. This search was updated on May 9th, 2023, so it's very recent results. Here you can see our first forest plot for the diagnostic adequacy. As you can see, it's a risk ratio of 1.06, so we don't really see a difference, and we have a very low level of evidence due to the wide confidence interval. However, we also noticed that one study was very clearly clinically and mathematically significantly in favor of contrast-enhanced endoscopic ultrasound, which struck us as strange, especially once we noticed their low adequacy rate in the conventional arm. We therefore looked at this paper more in detail, and we realized that the first pass in this paper was performed by inexperienced endoscopists under the guidance of an expert. However, we also saw that they had further passes performed by expert endoscopists, and we decided to set up 2 further analyses using only passes by expert endoscopists. So the second forest plot here includes the second pass from that study, which is performed by expert endoscopists, where you can already see that the risk ratio is now 1.0. The confidence interval has become very narrow. Our level of evidence is moderate. We also, for safety's sake, we performed a third analysis, omitting the study entirely because we figured the second pass might introduce more heterogeneity than needed. So based on this, we would like to conclude relatively strongly that it does not, in fact, make a difference to use contrast-enhanced endoscopic ultrasound versus conventional in terms of diagnostic adequacy. For our secondary outcomes, only 1 paper reported the technical failures, again, 0 as compared to the other one. And we were able to pool the adverse events, but there was no difference in any of the papers. And again, very low event rates. There are currently 2 ongoing trials on this topic. However, we suspect that one of them is not actually ongoing, but a mistaken registration of one of our included studies. But our meta-analysis might need to be redone once these are published. To sum it up, only randomized controlled trials were included in this paper, and there was low risk of bias for the main outcome. However, we had few studies with differing methods and differing definitions, and a low number of events for the secondary outcomes, plus low or very low level of evidence for the secondary outcomes. We would like to conclude that there's likely no difference in diagnostic adequacy, but contrast-enhanced endoscopic ultrasound may aid inexperienced endosonographers in their beginning period. So it may only be worth using if only inexperienced endosonographers are available, and any further RCTs should consider stratifying for the experience. Current RCTs should report experience and lesion size, and this may need updating again. Currently, this is in revision at a D1 journal, Scientific Reports. We're in the second round now. So to sum it up, my goals here are to submit the network meta-analysis by July of this year, and the second project was submitted in December 2022. Here you see my additional activities. To save time, I won't list them up. I've been working a lot for the CTM, and I've been presenting at a lot of conferences, which has been great fun, and I'm very grateful to the CTM for making it possible. So with this quote, I would like to thank you for your attention. A good paper tells a story. A published paper cites reviewer 1, survives reviewer 2, and buys reviewer 3 a beer at the next conference. Thank you for your attention.
Fantastic. I just want to say one thing about the first study, that people don't like to publish negative results. So it's a terrible bias in those papers about what was successful and what wasn't. The second thing I want to say is that unfortunately, you have to look at who provides the money for those studies. You're going to have the companies for those particular needles pushing their particular project. And you have to be careful with that because you're a naive young person and don't fall into that trap. The third thing I want to say is I don't think you have any chance getting into gastroenterology. I think you should send it to clinical gastroenterology, which is slightly less. It's also very prestigious. But I think gastro won't take it, in my opinion.
I'm absolutely aware of that. I'm pretty sure neither would clinical gastroenterology. I'm probably going to end up sending it as well to digestive endoscopy, gastrointestinal endoscopy, but we're taught in this program to aim high first.
What about the companies? Did you look at the companies? Did you look at if companies were pushing those papers? Did you look at that?
I did. So unfortunately, the papers do say often in the end that, Cook, for example, Cook Medical provided the equipment, Boston Scientific provided the equipment. So of course, it's all throughout the papers.
Congratulations to your presentation. Very interesting results. My question is regarding to your second study, and if I remember well, for the last forest plot of the primary outcomes, I saw an outlier, and maybe I missed your explanation, but did you find any reason for it?
You mean this one study which was significant? Yes. So what we found there was that it was inexperienced endoscopers that were performing the procedure, and based on this we performed the other analyses, which then led us to conclude that there is no difference, except perhaps it could be suggested for inexperienced endoscopists.
So in the network meta-analysis, it's typically a questionable thing that what is the consistency of the comparison. So what does it mean, this consistency?
Well, consistency is looking at the indirect and direct comparisons and seeing if they correspond to each other, or if somehow due to the indirectness, we introduce some kind of error into the data.
And have you...
I have not presented it here. I don't know it off the top of my head yet, and these are not the final results, but it will, of course, end up in the final manuscript what the inconsistency was.
Thank you. So maybe do you have any other hypotheses for your second project, why there is no difference between the two methodology?
Actually, yes. So this was also discussed at length at previous conferences. Basically, the whole reason why it was suggested that contrast-enhanced endoscopic ultrasound might be better is a flawed concept, because both adenocarcinoma and the surrounding pancreatic tissues are both hypoenhancing normally. However, it might be useful in the setting of chronic pancreatitis, because in chronic pancreatitis, you have a lot of fibrosis, and in this case, you would be able to see the adenocarcinoma. So in my discussion, I'm also addressing this, that one of the included studies was looking whether chronic pancreatitis might or in the setting of chronic pancreatitis, why it might be helpful, but most likely for a healthy patient, it just isn't, because the tissues are too similar.
And could you differentiate for these data amongst your...
Unfortunately not. So this was not possible to do from this meta-analysis. Also, the paper that had looked at the chronic pancreatitis was underpowered to answer the question. They saw a trend, they didn't see statistically significant results. So it's more a suggestion for future research to maybe look into whether this technique can help in chronic pancreatitis. Because, of course, in chronic pancreatitis, you do see more pancreatic cancer than in healthy people.
I have another question. So in your meta-analysis, I have seen that you, in the conclusions or in the summary, you talked about credible intervals.
Yes.
So there was a Bayesian network meta-analysis.
I believe so.
Okay. Because looking the p-score tables, it looks like that it was the frequentist.
Most likely this was based on the first analysis. So I haven't updated the slides. I've continuously updated them. And as you were the statistician of this project, yes, I'm sure you also remember that the first analysis of this was done differently. We didn't get p-scores. It was back in December 2021. So
thank you very much for this nice presentation. You were the last, but you were one of the best.